Okay, welcome everyone to another Life and Breath Foundation educational webinar. My name is Saul Kachauskas. I'm a board member here at Life and Breath. We're very happy that you've joined us here tonight. We have a very interesting topic. It's NeuroSarcoidosis 101. Before I introduce tonight's speaker, a few words about Life and Breath Foundation. Our primary goals are to offer sarcoidosis community effective tools, track their journey, decipher medical issues, and maximize their quality of life. Also, to provide a nurturing environment for those affected by sarcoidosis, to share their experiences, build more awareness within the medical community to help combat this chronic disease. Also, what we do, Life and Breath, we're all volunteer. The money we receive through donations and sponsorships goes directly to supporting patients with sarcoidosis. The services we provide, multi-speaker series that you're part of tonight. We also have a Life and Breath Scholar program with physician education. This year we're doing it at Greater Baltimore Medical Center in Baltimore. We also have patient support from sarcoid experts, patient support through sponsorships and education. And we also have a My Life in Breath planner, which you can learn more about going to our website. Just also for your information, we have an event. It's Take a Breath for Sarcoidosis coming up Sunday, April 14th at Hydes, Maryland. It's at Dijon Vineyards. It's a 5K race or 1 mile walk. We also have folks that maybe can't be there or can't attend, so they can do the silent hero, or we also have virtual runs all around the world. So whichever way you want to join us, it's very exciting, and we're looking forward to it this next month. Okay, before I introduce our speaker, this webinar will not give medical advice. No doctor-patient relationship has been established by talking with Dr. Barreras during this meeting. Our speaker does not know your medical background and cannot therefore give you any specific medical advice. So please speak with your doctor before acting on any information you hear this evening. Okay, introducing our speaker, Dr. Paula Barreras. He is a board-certified neurologist with expertise in neuroimmunology. He is an assistant professor of neurology and part of the Neuroimmunology Center at Cedars-Sinai Medical Center. Dr. Barreras specializes in immune-mediated conditions affecting the brain and spinal cord, including neurosarcoidosis and other rare neuroimmunological disorders. Dr. Barreras completed her medical school at University of the Andes, followed by a postdoctoral research fellowship in neuroimmunology at Johns Hopkins University. She then completed her neurology residency and then clinical neuroimmunology fellowship with an emphasis in neurosarcoidosis, also at Johns Hopkins, before joining the team at Cedars-Sinai Medical Center in Los Angeles. Her research focuses on identifying predictors of outcomes in neurosarcoidosis and understanding the causes of sarcoidosis-associated small fiber neuropathy. Dr. Barreras, welcome. The floor is yours.
Well, thank you so much for that great introduction. Let me share my screen here. So I'll be talking about neurosarcoidosis. And I think the audience is familiar with sarcoidosis in general, but just as a brief introduction, we know that sarcoidosis is an immune-mediated disorder characterized by granulomas in various organs. So granulomas are here in the picture. That's just the type of inflammation specifically that we see in sarcoidosis. And usually in the biopsies, you'll see the buzzword of non-caseating. That just means no necrosis, or that's the buzzword that we look for to confirm the diagnosis. And when granulomas cause inflammation in various organs, that's what disrupts the function of the organ and causes symptoms or damage. This can affect any disease, most commonly the lungs, skin, and eyes, but can affect the nervous system. So what is neurosarcoidosis? Is when those granulomas cause inflammation in the nervous system. And the nervous system would be the brain, the spinal cord, the peripheral nerves, or the muscles. And I put a picture of a highway here because I like to think about the nervous system as a highway in many ways. Your brain sends signals through this highway that is the spinal cord, and then a network of smaller roads to your extremities to move, to your muscles, to your bowel and bladder for control, and then signals come also from the receptors in the skin through that highway back to the brain to bring signals about sensations in the world, feeling pain, feeling temperature, feeling vibration, proprioception. So whenever there is a problem at any point in that highway or smaller roads, then there is a traffic jam and the signal doesn't get through. And when the signal doesn't get through, then symptoms appear of weakness or numbness or tingling or pain, which symptom will depend on where that traffic jam is. How frequent is neurosarcoidosis? So this is rare, but probably under-recognized. I believe it's probably more common than reported because people just don't think about it as often as I hope they would. Neurosarcoidosis affects, depending on the study you quote, between 5 to 35% of patients with systemic disease. There was a study done in Southwest England and Wales that reported an incidence of 1 in 100,000. But again, we probably need more studies to understand the real frequency in our population. Isolated neurosarcoidosis, meaning when there's no sarcoidosis anywhere else, just in the nervous system, occurs in 10 to 40% of people with neurosarcoidosis. And 84% of patients eventually do develop systemic manifestations of sarcoidosis. Now, of those that do have neurosarcoidosis, most patients had neurological symptoms as the first presentation of the disease. Why is this important? This is important because neurological involvement in sarcoidosis is associated with increased risk of death and increased risk of disability. So it's very important to identify it early and treat it appropriately so we can prevent those bad outcomes. So who gets neurosarcoidosis? Essentially, anybody with systemic sarcoidosis is at risk. Often occurs more commonly in the fourth decade of life, and women are more commonly affected. It can happen across any ethnicities. Most patients reported in the literature with neurosarcoidosis are Caucasian, followed by patients of African descent, but it can occur really in anybody. 75% of those with neurosarcoidosis will get that neurological involvement within 2 years or of the sarcoidosis diagnosis. So it's really that early period that is critical to screen for disease, in different organs, including the nervous system. So how do people present with neurosarcoidosis? What are the symptoms? So most commonly, neurosarcoidosis presents with cranial neuropathies. So what that is the nerves that come out of the brain to move our eyes around, provide sensation to the face, to move the face muscles, hearing, swallowing. Those nerves can get inflamed and then people would get symptoms. Most often, then those symptoms are facial palsy. A lot of times people get told that they had a Bell's palsy and they leave it at that when it was probably the first manifestation of sarcoidosis. People can have optic nerve disease, so the nerve in the eye can get affected and that leads to visual problems like a black spot in the middle of the vision, pain with the eye movements, decreased visual acuity. After that, the most common symptom is headaches because, and we'll see later, sarcoidosis can cause a chronic form of meningitis manifesting primarily as headaches. After that, most common symptoms are sensory symptoms like numbness, tingling, or pins and needles sensation, followed by muscle weakness, then problems with balance and walking, and more rarely it can cause seizures or muscle spasms. Now, this is an anatomy cartoon. I'm not going to quiz anybody later, but this is just to illustrate how complex the brainstem is. And these are all the cranial nerves that come out of that, of the brain and the brainstem to provide different functions. And these are, depending on which nerve is affected, the various manifestations that neurosarcoidosis can have. So we can have problems with the optic nerve that would cause vision problems. We can have problems with the individual nerves that move the different muscles that go to the muscles that move the eye. And then if those are affected, usually the symptom is double vision, seeing two objects instead of one. And there are nuances to that. People can have horizontal double vision or vertical double vision, depending on which nerve is affected. There is a nerve called the trigeminal nerve that is in charge of the sensation of the face. So if that's affected, people can have numbness in the face, but often pain in the face or headaches in the superior, in the forehead, that are often mislabeled as migraines in people that actually have neurosarcoidosis. And then the lower cranial nerves really control hearing and swallowing, and sometimes voice. So people can have changes in voice, where the voice becomes softer or hoarse, and trouble swallowing as part of the manifestation of sarcoidosis. In 40% or more of cases that have one of those nerves affected, there are multiple nerves affected. And when there's both sides, that's a red flag that this is probably sarcoidosis. So in anybody who's had a Bell's palsy more than once, then we should really think about neurosarcoidosis, as more so if it's both sides at the same time. After that facial nerve, the next most important one, or relatively common, is vestibulocochlear nerves, affecting hearing and also balance. And like I said, that trigeminal nerve can manifest with facial pain, numbness, or headaches, or followed by double vision if other nerves are affected. This is a cartoon, well, not a cartoon, this is an MRI view of the optic nerve. So those round balls are the eyes. This is, looking sort of from above. And the arrows are pointing to the white areas that are inflamed. And this is, the inflammation secondary to sarcoidosis and how it can affect different parts of that optic nerve. Usually, it can be the optic nerve itself, like in the first panel A. The inflammation can be around the optic nerves or in nearby structures, or it can go to the back portion of the optic nerves. And depending on where within that visual system the inflammation is, then the symptoms in vision can be different. Can be just one eye, or both eyes affected, or just one side of the visual field. Now, this vision loss, like I said, it varies depending, the pattern varies depending on which area is affected. So once there is involvement of that optic nerve, the vision loss can be in the center or can be in the periphery. And often this is subacute, which means it evolves gradually over days to weeks before stabilizes or improves. But it can also be more chronic and sort of be gradually worsening over several months. Sometimes people get mislabeled as, oh, this is just cataracts or something like that, when it's actually neurosarcoidosis. It can affect both eyes at the same time in a third of patients. And it can come with pain with eye movements in a third of patients, but not always. Now, sarcoidosis, other than affecting the neurological part of the eye, can affect the eyeball itself or the anterior aspect of the eye. So often when there is that involvement of the optic nerve, it comes with uveitis or inflammation in the lacrimal gland or around the other ophthalmological structures. So getting a good ophthalmologist on board is also key to look for that, because that inflammation can be initially silent or produce mild symptoms that may be ignored. Now, MRIs of the brain are not enough. So a lot of times people get an MRI of the brain and they are told, oh, your optic nerve is fine, I don't know what you have, but really we need to get a dedicated MRI of the orbits, which is a special sequence to really take a look at that optic nerve, because the MRI of the brain often skips a good portion of it and we may not see it. Now, meningeal disease. So the meninges are the covering layer that protects the brain. So it's not the brain itself, it's the covering of it. And when the meninges are inflamed, then usually the symptom is headache. And if the inflammation is severe, because that's directly touching the brain, then it can lead to things like seizures. And the cranial nerves that I was talking about come out of the brain through those meninges to their target organs. So if the inflammation is in the meninges, then not only people can have headaches and seizures, but then often comes with that cranial nerve involvement. Symptomatic meningitis is relatively common in 20% of people with neurosarcoidosis, but asymptomatic meningitis can be seen in 67% of the patients. So somebody presents, let's say, with a Bell's palsy, they do an MRI and they see that the meninges are inflamed, although that person didn't have symptoms of a meningitis. Now, these are MRI pictures just showing the different aspects that meningitis in sarcoidosis can have. And I don't want to get too technical, but essentially the white areas are what's abnormal. The normal color of the brain is gray, and the meninges can be just smoothly inflamed, and thickened, like in pictures C and D. Often those patients have a lot of headaches, but it also can be bulky and mimic a tumor. So it can be attached to the meninges, but cause mass effect and push on the brain itself, and that leads to, different type of symptoms, often, leading to more deficits depending on the area of the brain that is pushing. And like I said, it can mimic a tumor. So often there is a concern for tumor. These patients get referred erroneously to a neurosurgeon, end up in a surgery, and maybe this would have resolved with steroids. Now, neurosurgeons do have a role, if there is significant mass effect, then the mass may have to be removed just for symptom relief. And then we have parenchymal disease, which is just the buzzword to say sarcoidosis in the brain tissue itself. It can take many forms. It could be lesions that are diffusely there or may mimic actually multiple sclerosis. So it's not uncommon that people get, they are told initially, oh, you have MS, and then, oh, it's not MS, it's sarcoidosis, or we don't know, it kind of looks like MS, but it looks a little weird. That's one type of lesion, but like I said, not uncommonly, lesions can be bulky and mimic tumors. So that's the other big type of lesion we see in neurosarcoidosis. Symptoms will depend on where in the brain this lesion is, how big it is, and how inflamed it is. Often, the symptoms of these lesions are deficits in, let's say, like the ability to move an arm or a leg, or numbness in one side of the body. Symptoms can be seizures, or if the lesions are in certain parts of the brain, can present with behavioral changes, personality changes, more impulsivity, memory problems. Now, spinal cord involvement, which is one of my areas of interest. The reason I like, not that I like, I mean, this is something that I don't wish on anybody, but I like it because it's misrecognized, and I think there's so much work to be done here. Usually in sarcoidosis, the spinal cord can get involved with these very long, bulky lesions that are usually expanding the spinal cord over multiple segments. And we've described in our work, and other groups have done so too, that really in sarcoidosis, the spinal cord lesions are more posterior, meaning the back part of the spinal cord. And that back portion of the spinal cord is where the fibers for sensation live and for pain. So usually people present with a lot of pain syndromes, with a lot of numbness, and something that is called proprioception deficit. So like not knowing where your legs are in space, which feels like you're like floating, or just feeling unbalanced, but there's no weakness. So sometimes people are dismissed because they go and they check their strength. The strength is fine, but actually it's a proprioception issue. This usually is seen very well in an MRI. The MRI has to be done with contrast, because if without contrast, we will miss the specific patterns that would tell us that this is probably sarcoidosis. And other type of lesions similar to the brain, bulky, round, mimicking tumors, can occur. In cases of spinal cord involvement, often people get labeled transverse myelitis initially, which just means inflammation of the spinal cord. And sometimes that's given as a final diagnosis without querying what's the cause behind that inflammation, and leads to a lot of misdiagnosis and wait time to a correct diagnosis, especially in people that first present with a spinal cord disorder. This can happen in 15 to 20%. And whenever there is involvement of the spinal cord, people tend to have exacerbations in the same area. So it's like the inflammation is there, we get it controlled with steroids or with other medications, and when it comes back in the same area, which is different, for example, from disorders like multiple sclerosis, where new lesions accumulate in different parts of the nervous system. Now, sarcoidosis also likes to go to the pituitary and the hypothalamus. Those are in the brain. It's essentially the hormone center of the brain. So it's the area of the brain that controls all the hormones that regulate our blood pressure or sugar or thyroid function, testosterone production. So because of that, people can present with symptoms of low thyroid, low blood pressure, low loss of libido and sexual dysfunction. And it's important to advocate I will say in any patient with sarcoidosis, to check for these hormones, just as a screening early in the course. Because as opposed to sarcoidosis in some other places where there's inflammation, and once the inflammation is gone, things get better. With these, things tend not to get better. So even if the inflammation is gone, the hormones don't get back to normal. And often people benefit from, let's say, testosterone replacement or thyroid replacement, and that can make a huge difference in symptoms like fatigue, which is so common in sarcoidosis. There are strokes that can occur as a consequence of neurosarcoidosis. This is fortunately very rare, but it can happen if the sarcoidosis inflammation is around the blood vessels and blocks them off. But also if sarcoidosis affects the heart can get inflamed, have abnormal heart rhythms, and then blood clots can form inside the heart, and those clots can get thrown to the brain and cause a stroke. And there's muscle involvement too. This is less common as a cause of symptoms, but it's very common without symptoms. So in autopsy studies, they've seen sarcoidosis in the muscles in 50 to 80% of cases of patients with sarcoidosis, but often they were asymptomatic, and it's not usually a cause of concern. Now, also rare, peripheral neuropathy. So it's relatively common for people with sarcoidosis to have sensations of tingling and numbness, usually in the feet and arms. Most commonly, the cause of that is diabetes, which is common in our patients because we use a lot of steroids and prednisone, which can lead to diabetes. So diabetes is the leading cause of peripheral neuropathy worldwide, but sometimes it's not diabetes, sometimes it's sarcoidosis itself. And it's important to try to differentiate those two. It's hard, but it's important because in one case, the steroids would be the treatment, and in the other case, the steroids may aggravate the situation. So it's really good to try to go to a specialist. If the problem is peripheral neuropathy, that would be a neuromuscular specialist to try to tease those out. And finally, small fiber neuropathy is another type of neuropathy that we can see in sarcoidosis that can also cause numbness, tingling, pain in the arms and legs, but it's more patchy. It can affect the center of the chest, the center of the back, the upper thighs, and commonly comes with symptoms of dysautonomia, which is dysregulation of the autonomic nervous system, which is the system that controls blood pressure, heart rhythm, gastrointestinal function, bladder. So people can have lightheadedness, POTS, a lot of nausea, a lot of bladder dysfunction. This is actually relatively common. It's present in 30% of people with systemic sarcoidosis, not just nervous system sarcoidosis. And it's often also missed. It's diagnosed by a skin biopsy. And it's important to look for other causes because an alternative cause other than sarcoidosis is found in about 20% of people, the most common being also diabetes. So how do we diagnose neurosarcoidosis? So once we have one of those syndromes that I described, a compatible presentation, Then we do the MRIs or the nerve conduction study if it's a peripheral case. And then we know that certain MRI patterns are seen in sarcoidosis. So you want to be seen hopefully by somebody with expertise in neurosarcoidosis that can recognize those patterns and say, okay, the clinical profile makes sense, the MRI makes sense, so this is probably neurosarcoidosis. Now, to confirm a diagnosis of sarcoidosis in any organ, ideally we want a biopsy that shows those granulomas that we talked about. Now, not as simple to biopsy the brain, right, as it is to biopsy the skin, let's say, or the lungs. So we try to not biopsy the nervous system if we can. So what we do is just look for other organs that are involved, and that's, it has to be very thorough evaluation, and then try to biopsy somewhere else. If we can't find another biopsy target, sometimes we do have to biopsy the nervous system, and we'll talk about that in a second. Now, also important is to exclude mimics of sarcoidosis, because even if something can look like sarcoidosis, it could be an infection, it could be a tumor, it could be lymphoma. So there has to be a careful evaluation to rule out those other mimics before we can call this neurosarcoidosis. So usually the neurologist or the physician seeing the patient would do a history, recognize the disease, do the MRI, and then, unless contraindicated, I advocate that everybody should get a lumbar puncture for cerebrospinal fluid analysis. So that's the fluid that it's around the brain and around the spinal cord. And we can take fluid and send it to the lab. And it's useful for several reasons. It can confirm whether there's inflammation in there. But most importantly, we can send that fluid and check for infections and check for cancer, which are two of the things that mimic sarcoidosis. So by doing that safety check, we can say, this kind of looks like neurosarcoidosis. We've checked that there's no evidence of infection. We've checked that there's no evidence of cancer. Maybe we'll hold off on that brain biopsy and treat you as neurosarcoidosis and see if you get better. And that's a valid approach as long as we're careful about excluding those other causes. Now, if this is the first presentation and it's a neurological manifestation, then like I said before, we really need to look thoroughly for sarcoidosis elsewhere. And the way that's done is usually either by getting a PET scan of the body, which it's a special type of scan that looks for inflammation in other organs, or going organ by organ and really screening for sarcoidosis. So an ophthalmological evaluation looking at inflammation in the eye, an ENT evaluation looking for inflammation in inside the nose, doing a chest CT looking for sarcoidosis in the lungs, and so forth. The most common mimics are tuberculosis and fungal infections. So those need to be absolutely screened for in both the blood, ideally the spinal fluid, and if a biopsy is done, in the biopsy. And then we need to do cancer screening. Other mimics are rheumatological disorders. Things like lupus, Sjogren's can affect the spinal cord and look kind of similar, or multiple sclerosis, and CVID is another disorder that can also manifest in a similar way. Those are less common, and I think to expert eyes, less likely confounders than things like tuberculosis or fungal infections. Now that lumbar puncture, because I know that at least a lot of my patients give me a look when I suggest this procedure. So I just wanted to say that it's safe in the large majority of patients. This is not something that needs general anesthesia. We do it in the bedside. It's a needle in the lower back. And I think, again, it's important because it allows us to confirm inflammation and check for infection and malignancy. That biopsy of the brain or the spinal cord. So it's not always needed, and I try to avoid it because biopsying the brain can lead to, if you take a piece that was doing something useful and you remove it, then you may be left with a deficit as a consequence of the biopsy itself, and we don't want that. Now, it's important to confirm the diagnosis though, right? Because we don't want to say, I may or not have sarcoidosis, but I'm taking steroids forever, right? That's not ideal. So as much as we can, we like to confirm the diagnosis. And it's relatively safe and easy to do a meningeal biopsy. So if in the MRI, the meninges are involved, that's that covering layer, not the brain itself, that's an easy biopsy to do. That's safe, and it's routinely done in the hands of a good neurosurgeon. The risk is very low. So those we do frequently. Now, if there is concern for tumor, let's say a bulky brain lesion, and we don't know what it is, and we really couldn't find sarcoidosis elsewhere, sometimes we do small brain biopsies, and that's okay. Most people do well with those, and I think it's important to clarify the diagnosis and especially exclude the possibility of a tumor, because the treatment would be very different. Now, in the case of the spinal cord, I really don't recommend biopsy in general because it's very tiny, the spinal cord, so even taking a small piece can lead to a lot of neurological problems as a consequence of the procedure. So we only do this if we absolutely have to, and that would mean we empirically treated a sarcoidosis and there was no response, or we're very concerned that the spinal cord problem is a tumor. So once somebody has neurosarcoidosis, or we think they have neurosarcoidosis, because often the diagnosis is not initially confirmed, the first line of treatment is steroids. And often we consider neurological involvement severe. So somebody with a big brain lesion, multiple like cranial nerves moving the eyes around, causing vision impairment, spinal cord disorders. We give usually IV methylprednisolone, so high dose IV steroids for 3 to 5 days. That usually happens in the hospital. Sometimes can be arranged as home infusions, but only if the presentation is not that bad. Let's say something like numbness only, but no weakness or something like that. Usually this is followed by a steroid taper. So we treat with high dose steroids and then we send the person out, usually on prednisone by mouth at a high dose still, to be decreased very slowly over several months. And in my experience, people often need a low dose of prednisone to keep control, even if they have other medications on board. This may be a little different from what we see in pulmonary sarcoidosis, for example, when people are used to doses of 10, 20 milligrams of prednisone. With neurological disease, we sometimes start much higher. So doses of 50, 60 milligrams of prednisone are not unusual here. Now, like I said, sometimes people do need long-term steroids, but steroids, it's a love-hate relationship. We love them because they work, but they have a lot of complications, including decompensating mood disorders. So if somebody has bipolar disorder, they can get hyper or even psychotic with steroids. People can have sleep disruptions, or osteoporosis can be aggravated. They can lead to decompensation for hypertension or diabetes and ulcers, cataracts. So we don't like them, if we can avoid them. So typically what we do is that we try to reduce the dose gradually. And if we run into trouble with the disease getting worse, then we go back up. And we try that, or we should try that, I think, as often as we can. Once the person is stable, we try again. Because sometimes after a while, the disease cools off and then allows us to do that. We shouldn't be just on 60 of prednisone and leave it at that long term, because that would cause a lot of problems. Now, one thing that allows us to reduce the need for steroids is starting a second treatment. And we call those steroid-sparing agents because they allow us to spare the steroids. And these are medications that modulate the immune system to reduce inflammation. And when you quiet down the immune system, that comes with a risk of infection. So that's usually the risk in general for all of these medications. So these are the most commonly used medications for neurosarcoidosis. These are the names of the medications in the first column, and then the usual doses, and then the usual side effects that we monitor for. The ones that have a star, methotrexate and infliximab, are the ones that have the better quality data to suggest that they work better, or best in neurosarcoidosis specifically. So things like azathioprine, are perfectly reasonable choices for systemic sarcoidosis, let's say lung sarcoidosis. If somebody has severe brain disease, I'm not gonna go there because it takes first too long to become biologically active. So it can be that somebody's taking this for a couple of months before it even kicks in. So that's usually not fast enough for what we want with the brain or the spinal cord. And it's not that effective. It just in my experience doesn't work that well. So we do use methotrexate. There have been studies comparing methotrexate to CellCept and azathioprine. CellCept would be mycophenolate mofetil. And methotrexate has better performance than the other two. We still use the other two sometimes, but methotrexate just has better survival for the patients on methotrexate compared to the other two. Methotrexate is a pill that it's taken by mouth, usually once a week. There's an injectable form too. So for those that have a lot of gastric side effects with it, injections, are an option. Then CellCept is usually a pill that's taken twice a day as well. And all of those three medications can affect the cell counts, can irritate the liver. So we do need to monitor blood work regularly, at least every 3 to 6 months, usually more frequently at the beginning. And if those side effects do develop, if the white count becomes very low, there is a risk of infection associated with that. Now, infliximab and its cousin adalimumab, then these are the TNF-alpha inhibitors. They are not FDA approved, unfortunately, for sarcoidosis, but I hope that changes at some point soon, because really all the papers, scientific papers, are in favor of these medications being highly effective for neurosarcoidosis. The initial approach a few years ago in the literature was to use this for severe disease that did not respond to the first line of steroids or the second line of methotrexate. But really, the field is moving to using these medications earlier and earlier, because being the nervous system such a sensitive place, we don't really want to wait until failing, these other first and second line medications, because time is brain. So in my personal practice, I tend to use have a low threshold to jump to use TNF-alpha inhibitors, especially in spinal cord disease when things are a little bit more sensitive and riskier. So which of these? So like we said, methotrexate has a little bit better data than mycophenolate, but we still use both. This has been demonstrated across different studies with a lower relapse risk and better survival. And for infliximab, which is the most studied medication in neurosarcoidosis from the two, adalimumab is also used, but this one has more papers to support it. There are favorable clinical responses rating from like 70 to 90%, depending on which study you quote. And there are meta-analyses done. A meta-analysis is a type of study that takes a look at all the studies done on a topic and try to reach a consensus opinion that say that this works for neurosarcoidosis. So we do use it. This is an infusion that at the beginning is more frequent, but once you go through that induction phase, the maintenance infusions are usually every 4 to 8 weeks, depending on the severity. So if somebody's stable, they can get away with just every 8 weeks. If somebody has more severe disease, can be as frequent as every 4 weeks. This is a stronger medication in terms of immunosuppression than the first three that are oral medications that I talked about. So it comes with the risk of, high risk of infection, including reactivation of chronic infections like hepatitis or tuberculosis. So it's important to screen for those before you start a medication like this. And then something that we need to be aware of is that people can develop anti-drug antibodies. So what does that mean? You get the infusion and then your body reacts to the medication as something foreign and then forms antibodies against the drug, and that makes it less effective, and it's associated with a high risk of infusion reactions like allergy type reactions. To prevent that, we often use a very low dose of either CellCept, azathioprine, or methotrexate in conjunction with the infliximab, because that low dose of the second medication allows or reduces the risk of these anti-drug antibodies happening. So often when somebody's in this medication, they're actually on both, on this and a little bit of methotrexate, for example. Now, there's a lot that we don't know in neurosarcoidosis, and we're actively trying to find out. So we need to understand better what's a good biomarker for diagnosis, so we don't have to go through all of those checklists that I showed you before, and to better understand who, prognostic factors, who's going to relapse and who's not, and who's going to have severe disability and who's going to do well. And we don't know, but a lot of smart people trying to figure this out. And every time I interact with my colleagues, I'm happy to see that more and more people are taking interest in neurosarcoidosis, and there are more research studies being done. So that's all I had for now. And there's a lot of questions that were sent, so I wanted to allow for time to answer those questions. And that's it. So I'll stop sharing the screen, and I guess we can get to the questions.
Thank you, Dr. Barreras. Actually, a lot of information. So no wonder that we have a lot of questions tonight. I'll try to split the questions between live and the ones that were submitted during registration, because I think both will provide a lot of benefit to the audience. So let me start first by one online. If you have systemic sarcoidosis, when and how should you be evaluated for this?
So I think early on. So the first time you get a diagnosis of systemic sarcoidosis, there should be a screening in the interview for symptoms of involvement in other organs, including the nervous system. So there should be at minimum a question of, anything else has developed. Do you have any weakness, any numbness, any vision changes? And if in absence of any symptoms, then it's okay to not necessarily go and get an MRI. But at minimum, the symptoms should be screened, at onset of this diagnosis, but frequently, in the follow-ups, because anybody with systemic sarcoidosis is at risk of developing neurosarcoidosis.
Thank you. Next question, what is the best way to get diagnosed with brain, spine, small nerve sarcoidosis?
An MRI, well, first, a good history and physical exam. And I think people have to think about it to screen for it. So it's important to advocate for yourself, right? If you have symptoms of these, or you think you may have this and nobody's asking you about it, just bring it up in your next follow-up appointment. And the test of choice for brain and spinal cord is an MRI with contrast. Not uncommonly, it's done by mistake without contrast, reported normal, and people move on. So MRI would be the first step.
Thank you. Next question, is there a way to distinguish peripheral nerve pain from neurosarcoidosis versus sciatica radiating pain or joint radiating pain and leg muscle weakness?
So there is, they can be similar, and often, it's not immediate to tell the difference, because those conditions all can cause pain in the same regions of the body. But for example, an MRI of the lumbar spine with contrast in sarcoidosis could show inflammation of the nerve roots or of the lower spinal cord. Or if this is sciatica or a disc, it would show the disc pushing on the nerve, and then it's not sarcoidosis, it's a compressive issue. So the MRI is a good test. Then a nerve conduction study, or EMG, which is a needle test where they measure the conduction of the nerves, can help us localize where the problem is, if it's a nerve problem or a muscle problem, and which nerve is affected. So usually those two things are part of that evaluation, and depending on the results, we can usually tell apart the difference.
Thank you. Next question, I have multi-system sarcoidosis, primary lungs, heart, eye, skin, and neuro. What is the ideal treatment for neurosarcoidosis? They're on gabapentin, 1,200 milligrams per day. Just wondering, what would that be as an ideal treatment?
Yeah, so I think I'm glad this question came up, because there are two types of treatment in neurology, in neurosarcoidosis. One is the treatment for the inflammation itself, for the sarcoidosis, which is to prevent further attacks, further inflammation, and keep the inflammation under control. And there are the symptoms that the medications that help with the symptoms. So sometimes there's inflammation in the nervous system that is well controlled, but there was damage that was done. And the consequence of that damage is, for example, ongoing tingling sensations or ongoing pain, even if the inflammation is gone. And that's where medications like gabapentin come and are useful. That gabapentin specifically is a medication for the nerve pain from prior damage that's not treating the sarcoidosis. Now, in somebody who has multi-organ disease, including neuro, I would advocate for TNF-alpha inhibitors like infliximab or adalimumab if the involvement is severe. Now, sometimes the lung involvement is quiet and the neurological involvement maybe was 10 years ago and things are stable, then maybe somebody can be on, let's say, methotrexate alone if things are stable. But I would have a low threshold to use TNF-alpha inhibitors in somebody with severe multi-organ disease.
Thank you. Next question, could neurosarcoidosis cause hemorrhage in the brain?
It can. It's very rare, but it can, because the inflammation can be in the veins in the brain or in the small arteries. And if severe enough, those small vessels can rupture and bleed.
Next question, do you have any patients that get lesions on their cerebellum?
Yes. So sarcoidosis can affect any part of the brain or the spinal cord. The cerebellum is the back part of the brain. And sarcoidosis preferentially affects the base of the brain. So a lot of brainstem involvement, but we can occasionally see cerebellum lesions.
Next question, can neurosarcoidosis present as a pituitary tumor that hemorrhaged abutting the optic chiasm and or as a fourth cranial nerve palsy in one eye?
Yes, it can. So that pituitary area that I told you about, that was the hormone center of the brain. So that's an area that sarcoidosis likes to go. And when that pituitary is inflamed, it looks bigger. And it's a relatively common area to have benign tumors called adenomas. So those two are often confused. So people get an MRI, the pituitary is enlarged, it's lighting up with the contrast. So they think, oh, you have a pituitary tumor. If the inflammation is severe, it can bleed. That's not as common as just having it enlarged and inflamed. If they do a biopsy, then they would see the sarcoidosis, and that is not a tumor. But that area is a very sensitive area that is right on top of the optic chiasm, which is a part of the visual pathway. So even if there is large inflammation without bleeding, or if there's bleeding, which is more serious, then it can affect vision and lead to problems.
Yeah. Next question, when the PET scan shows no longer any activity, but I still have tingling and numbness in my legs, can the disease still be active?
So yes and no. So getting back to the point that I made earlier, sometimes people can have inflammation, let's say from the spinal cord or the nerves, and the inflammation can be gone, but the symptoms can persist, which can be frustrating for everyone. But it's not uncommon that those symptoms are just a consequence of the prior damage. So people can persist having tingling, can persist having pain or having numbness. You can think about the sarcoidosis leaving a scar and a traffic jam permanently there, and the signal doesn't get through. And that's when medications to treat the symptoms are important, things like gabapentin for tingling, for example, like we said before. Now, PET scan tends to look at the inflammation in the body, and is very commonly the test of choice to follow cardiac sarcoidosis or lung sarcoidosis. To monitor neurosarcoidosis, we usually go with the MRI with contrast. And often we see that the enhancement with contrast, that's the lighting up with the contrast, was there, markedly there, and then we want it gone. So once it's gone, in general, we consider that the disease is no longer active. Sometimes there's a little bit left. And that's when it's tricky, is there still a little inflammation that we haven't been able to treat, or that's just like a scar that can look similar. But often if the enhancement is gone, we consider that the inflammation is gone and just treat the symptoms.
Thank you. Next question, can neurosarcoidosis cause memory loss?
It can. It depends a lot on what area of the brain is affected, but it commonly does cause memory problems if the frontal lobes are involved. If there is something called hydrocephalus, which is as a consequence of chronic inflammation in the meninges, the fluid spaces in the brain get enlarged. That's complex, but anyway, that can happen. And that can manifest with somnolence, confusion, memory problems.
Yeah. Are there any correlations between neurosarcoidosis and cancer? If so, what type of cancer and what type of treatment would be best?
Not specifically with neurosarcoidosis, but there is a link, a small increased risk of lymphoma in sarcoidosis in general. Lymphoma is a cancer of the white blood cells. So if, that just is something to be aware of, and, often in these medications, there is also a risk of lymphoma. So things like TNF-alpha inhibitors, like azathioprine, carry a little bit of increased risk of lymphoma too. So just having sarcoidosis plus being on these medications increase that risk. So not to say that we shouldn't use the medications, we use them because they're needed, but we just need to monitor for that.
Thank you. Next question, can frequent urination be a sign of pituitary issues? What type of doctor could diagnose this?
So yes, pituitary issues. So the pituitary can do many things because, like I said, is the hormone center of the whole body, really. And when there's hormonal derangements, that can affect how much fluid you retain or urinate, how much your sodium or your salt levels fluctuate. And sometimes when people have very high sodium levels, salt levels from damage in the pituitary, that leads to a lot of thirst, a lot of urination. That's called diabetes insipidus. But there's also, the possibility of just regular diabetes with increased blood sugars that can also lead to a lot of urination, and spinal cord problems and small fiber neuropathy can lead to bladder problems and increased urinary frequency too, independent of pituitary damage. So so bladder problems, including increased urinary frequency, are a symptom of neurosarcoidosis and needs to be, evaluated. The specialist will depend if there is it will depend on the workup. So initially, your general sarcoidosis doctor should do a screening. If the exam or other symptoms are concerning, probably an MRI of the spinal cord would be what I would do. If this is coming from the pituitary, based on labs, usually you need an endocrinologist on board to regulate that problem, and that will take care of the frequent urination.
Thank you. Next question. I have essential nervous system neurosarcoidosis, right lacrimal gland biopsy, developed myopathy from prednisone. What is the best treatment at this point?
Okay. Well, the problem is that, like I said, prednisone can, when we use it for a long time, can give many side effects. Myopathy, which is a problem with the muscles, is one of them. And if that's the case, then that really limits how much prednisone this person should be on and indicates the need for a second medication, like one of those steroid-sparing agents, to suppress the inflammation from the sarcoidosis and not need that much steroid. So in that case, if things are in the lacrimal gland and in the eye, and I don't know the severity or know this person, right? But methotrexate would be a reasonable choice. If things are severe, then something like a TNF-alpha inhibitor.
Thank you. Next question, with small fiber neuropathy and or peripheral neuropathy, is it possible to feel both burning sensations and other pains such as sharp pain or dull in various areas as well?
Yes. Actually, burning is the most common symptom reported in a small fiber neuropathy. And it's a little weird in the sense that people can have numbness and hypersensitivity at the same time in the same area of the body. So it's on formal testing, often there is numbness for temperature sensation, but then that's the area that the patient reports that it's burning or tingling. Very common symptom in small fiber neuropathy and sarcoidosis.
Next question. Remicade seems to have become a popular treatment. Any thoughts on why it's been so promising?
Absolutely. So that Remicade is the brand name for infliximab. There are other brand names. You may know it as Absola as well. But the generic name, the substance that we're talking about, is infliximab, which is one of those TNF-alpha inhibitors that has been studied in neurosarcoidosis. So it's become popular because it works. We've seen across the studies that even in people with severe disease and disease that did not respond to steroids or azathioprine, mycophenolate, methotrexate, they can still respond to infliximab. So now the more information that we learn, we see that it actually works very well for neurosarcoidosis. So that's why it's become popular. And why it works is because those granulomas that are really the key for the inflammation in sarcoidosis need TNF-alpha signaling. So that's just a molecule that floats in the blood and speaks to the cells that form the granulomas. So that's needed to form and maintain those granulomas. So the medication disrupts that signal, and then the granulomas sort of melt away. So it's very nice because it tackles directly where the cause of the problem.
Thank you. Next question. Are you able to confirm all instances of neurosarcoidosis with a biopsy, MRI, PET scan, CT scan, EMG of the nerves, or is there a combination of blood tests, symptoms, other systems impacted or biopsied that help clinicians to find suspected cases?
Yeah, so all of the above. So the diagnosis really starts with a good clinical suspicion. So people need to have symptoms that fit with what we know about sarcoidosis. Then usually imaging features, MRIs or nerve conduction studies, depending on which area is affected, that make sense, that look like sarcoidosis. Then there's that important layer of we need to rule out tuberculosis, we need to rule out fungal infections, we need to rule out cancer. So there's usually some evaluation that goes into that. And we do the biopsy often of other organs. And if those other organs show me that there is sarcoidosis elsewhere in the body and I've excluded those other things, we call that probable neurosarcoidosis. We don't call it definite until we have a biopsy of the actual brain or spinal cord or nerves. But a lot of times we leave it at that and we say, this is probable neurosarcoidosis, but with that is enough to treat as neurosarcoidosis because the suspicion is very high. And if we cannot biopsy somewhere else, we sometimes biopsy the brain and then we confirm it. That should take care of the diagnosis in probably 99% of people. We can always say, we cannot say 100% in medicine ever. So there's always the exception where, let's say, somebody has neurosarcoidosis in an area that is not safe to biopsy, and it's isolated nervous system disease. So we cannot really biopsy the brain and we don't have anything else to biopsy. So that's possible neurosarcoidosis. We still treat as sarcoidosis if the suspicion is high enough and we've excluded other causes. But it's just, the caveat would be if things don't go as planned, then we need to reassess the situation. But there are cases like that where we cannot confirm the diagnosis.
Okay, thank you very much. I am so sorry. We are running out of time. Could you answer one more question?
Sure.
Okay. It says, I have pulmonary, cardiac, lymph node, and now neurosarcoidosis. 2 TIAs since October, vasculitis, showing on brain scan and small fiber neuropathy. Horrible headache. My doctor ordered Remicade infusions every 2 weeks, then every 4 weeks after first 2 treatments. No prednisone. Is that normal not to start with prednisone for neurosarcoidosis?
Yes and no. So usually we do start with prednisone. Your doctor may have reasons not to do that. So let's say if somebody has diabetes or at risk for a problem from prednisone use, you have a bad cataracts or osteoporosis or things that we don't want to aggravate with prednisone, we may jump to something else. But if the neurosarcoidosis is just recently discovered, often we start with prednisone while we get the infusion set up. We, get a few infusions in, and then we peel off the prednisone.
Okay, this is just the last question. I think we can answer this a number of ways. Dr. Barreras, where and how can we contact you?
Thank you. Well, I'm at Cedars-Sinai Medical Center now, and we here have a multidisciplinary sarcoidosis group. So I do work with colleagues in pulmonary medicine, cardiology, rheumatology, endocrinology. So a little bit of self-advertisement here, I guess. We do have a multidisciplinary center, and we're happy to see people and get them to the appropriate place. So I'll maybe put, I guess, in the chat the scheduling line for the clinic. Let me see, 6472. Let me 6%. Okay, so that's I think that was only seen by the panelist. So, but
we'll make sure we.
Yeah, it was in my last
slide.
For anybody who's interested in seeing us. So we're in the Southern California, in Los Angeles. There are other good centers for neurosarcoidosis. I'll say UCSF also has a great group. Johns Hopkins also has a good group. So depending on where you are regionally, there are places to go. Not as many as we would like, but happy to see you if you're in this area.
Dr. Barreras, I think, wow, a lot of information. I wish we could answer all the questions. We'll see if we can do something offline. Thank you very much for a wonderful, very comprehensive, thorough presentation. Thanks for everybody who attended tonight and participated with Q&As. Again, we provide these educational webinars every month, so please check our website for upcoming talks. Thank you again, Dr. Barreras, very much. I think it's been very helpful for our patients.
Okay.
Everyone have a great night.
Good night.
Thank you.